Hi, I'm Peter Carlobos, and I will be showing you how to perform tracheostomy. Tracheostomy refers to the creation of a communication between the trachea and the overlying skin. What is the difference between tracheostomy and tracheotomy? Tracheotomy is the formation of an opening that will close spontaneously once the tracheotomy tube has been decannulated, whereas tracheostomy is the formation of a permanent opening that remains open after the removal of the tube. What are the indications of tracheostomy? Tracheostomy is indicated among others in patients with upper airway obstruction, for respiratory support, pulmonary hygiene, for the elimination of dead space, treatment of obstructive sleep apnea, and prolonged mechanical ventilation, especially in those with respiratory disease, neuromuscular disease, and depressed mental status wherein the patient is unable to protect the airway. For the relevant anatomy, the important surface landmarks in tracheostomy include the laryngeal or thyroid prominence, jugular notch, cricothyroid membrane, and the cricoid cartilage. To avoid complications during tracheostomy, the following anatomical relationships are important. First, the inferior thyroid veins, which arise from the venous plexus of the thyroid gland and descend anterior to the trachea. Next, the left brachiocephalic, jugular venous arc, and pleurae may be encountered especially in infants and children. Third, the small thyroid ima artery, which presents in approximately 10% of patients. Fourth, the thymus, which covers the inferior part of the trachea in infants and children. And lastly, we should note that the trachea is small, mobile, and soft in infants, making it easier to cut the posterior wall. The instruments to be used are the following: local anesthetic, tracheostomy tube, suction, surgical set with a scalpel and forceps, electrocautery, and retractors. First, place the patient in a supine position with the neck extended by the pillow or bag placed under the shoulders to deliver the trachea out of the thorax and to give adequate access to the cervical trachea. Then, palpate and identify the surface landmarks, starting with the thyroid cartilage, cricoid cartilage, and suprasternal notch. Then, 2 finger breadths from the sternal notch, mark a line for incision. Then sterilize the skin of the anterior neck and chest, and then drape the patient properly. For the infiltration of the anesthetic, unless the patient can safely be intubated or the patient can be ventilated with a mask, a tracheostomy should be done under local anesthesia. The skin, soft tissue, and trachea should be infiltrated with local anesthesia with adrenaline before induction. Next, make a horizontal incision along the marked area through the dermis and the subcutaneous tissue is then dissected using an electrocautery. Intermittently palpating for the airway at this point is important as it is easier to stray from the midline. Once the fascia has been cleared away, identify the strap muscles and retract them laterally. Then, expose the trachea by carefully parting the overlying soft tissues with a pair of scissors. Tracheotomy is done between the second and third tracheal rings and extend it to an appropriate distance. Then create a York plaque for tracheostomy tube changes. Reflect the flap inferiorly and suture the flap to the skin. Then, insert the tracheostomy tube into the tracheostomy atraumatically that comfortably fits the tracheal lumen. Then secure the flanges of the tracheostomy tube and pass them around the neck. Tie them with the neck flexed. Complications of tracheostomy can be classified as intraprocedural, early or less than 7 days, and late or more than 7 days. Intraprocedural complications include airway fire, where despite being a rare complication, it is commonly found during tracheostomy. The drapes, ETT, and alcohol-based antiseptics are all potential fuel sources. Next is bleeding. Intraoperatively, most bleeding is secondary to anterior jugular vein injury or from the bleeding edge of the thyroid. Lastly, pneumothorax or pneumomediastinum, which may be due to direct injury to the pleura, dissection of air along the trachea, or rupture of an alveolar bleb. For the early complications, these include infection, tube obstruction. This comes from obstruction from the insippisated secretions due to the loss of natural warming and humidification of an airway, causing drying of the tracheal mucosa. Lastly, accidental decannulation, which has been associated with patients with altered mental status, increased secretions, and nursing shift changes. For the late complications, these include tracheal stenosis, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula.